Thank you. Okay. Great. Just to check in, everyone can see my screen, right?
Yes.
Perfect. Well, then let's just start. Welcome everyone to this webinar. I would like to welcome you on behalf of the team of Save the Children and Royal Tropical Institute to this webinar today, where we will be talking a bit more about the lessons learned on sexual violence research in conflict settings in times of COVID-19. Before we start and get into the content, I would like to take this opportunity to explain some technicalities with you so that you can have optimal participation in the webinar today. There are translation services today that are available in French and Arabic. Please make sure you can to select the language that you prefer by using the interpretation button at the bottom of your screen in Zoom. Once you've selected your language from the drop-down menu, please select Mute Original Audio in case you don't want to hear the English narration in the background. If you are on an Android or Apple mobile device, please click on the three dots in your meeting controls and then select Interpretation. You can select English, French, or Arabic. For any technical issues that you may be facing today, please type them into the chat box and our co-host Katie will assist you with this. If you lose your connection, don't worry, you can rejoin, and we will also have all the recordings available after the webinar in case you missed anything. For the best sound quality, everybody is muted, but in the latter part of the webinar, there is space for questions, answers, and a discussion. So for now, please keep your microphones muted until we have the Q&A session. And I'm going to take you through the program in just a second. Questions or comments can be raised or posted in the chat function during the presentation. In today's program, we're going to be having 3 speakers, and I'm shortly going to introduce 3 speakers today. We will have a discussion on the key findings, the lessons learned, the challenges, and dive a little bit into the specific challenges we faced in the different countries. Like I indicated, we will have a Q&A session towards the end and have a discussion on how we can follow up on these findings and hear a little bit more from the participants today that are with us. We have some final announcements to make at the end, and then we will have some closing remarks. So we want to get a sense of who is in the room with us today before we get on to the speakers. So Katie, if you could launch the poll. We have 5 very simple short questions. If you could answer these, and then we will share the results. Answers are coming in. So in case you still haven't participated, please do so. I'm going to give it a few more seconds. We also have participants joining in, so. Okay. Katie, do you want to share results? Great. So today in the room, we have quite a number of folks from NGOs or working or affiliated to NGOs when asked what kind of organization. We also wanted to have a look at if participants here have experience or have worked on sexual and gender-based violence, and quite a number, about 2/3 of the participants here have. With regards to, we do have quite a number of people who are also conducting research, and quite a few of those have also conducted research or worked in fragile settings. So again, about 2/3 of the group here. And the last, more fun question, in a very serious topic today: do you prefer the beach or the mountains? Oh wow, this is too hard, I can't choose. It's tied with the beach. Personally, I am a beach lover, so I can relate to that. And that's it for now. Let's get into knowing our speakers a little more. Great. So, today, oh, my apologies. Today we have Lindsay Kusters. She is a social scientist working for KIT as a senior sexual, reproductive, and health rights advisor with immense experience working in the sector and on sexual gender-based violence. She also has experience working in fragile contexts. Diana Maniere is a global health expert. She's currently the SRHR technical expert at Save the Children International, and has more than a decade of work experience working on this topic and creating demand and access to underserved groups. Sarah Ashraf, who is our third speaker for today, is a global health expert, currently working as a maternal, newborn, and reproductive health in emergencies. Advisor at Save the Children. She has 2 decades of experience, and particularly working in humanitarian and fragile settings on sexual reproductive health and rights. Before we go forward, let me tell you a little bit about why we're here today. So in 2013, Save the Children and KIT, Royal Tropical Institute, started the project Research for Change to assess the needs of survivors of sexual violence in humanitarian settings. This included 3 countries. We had Haiti, Yemen, and Nigeria. However, towards the end, we were only able to complete 2 studies in specific settings of Yemen and in Nigeria. And we'll talk a little bit more about that in the presentation. Today, we're here to share the lessons that we learned on conducting research on sexual violence and sexual and gender-based violence in conflict and disaster-prone areas, particularly in times of COVID-19. We will also touch upon the main findings of the study, so you'll get a sense of what the study was about, including 1, the types of violence, and 2, a reflection on the service provision and gaps for sexual violence survivors. This research was conducted with the financial and technical support of a committed team from the European Civil Protection and Humanitarian Aid Operations, ECHO. I'm here today as your moderator. I'm Tasneem Kakal, and I work with Lindsay at KIT Royal Tropical Institute as an advisor on sexual reproductive health and rights. I've also been very closely involved in the Nigeria leg of the research, and you'll hear more about that from my colleague Diana. So over to you, Lindsay.
Thank you, Tasneem, for this introduction of the webinar on lessons learned that we want to share with you, all participants. So good day to you all, and welcome to this webinar. So what we will present is, first of all, a bit of a background to the studies and more specificalities on the research sites. Then we will share some findings on the sexual violence in Borno State and South Yemen. But we will dig deepest in the challenges that we have faced during the execution and the setup and the dissemination of the researches conducted in these 2 countries, and also the types of mitigation strategies we used to deal with these challenges, and some overall reflections. And after that, we will go into the Q&A, so the question and answer session with you. So the next slide, please. So the Research for Change was initially a 2 years project that started in 2019. And this project was to assess on the responses to look at the needs of survivors of sexual violence in 3 very different humanitarian contexts. So Haiti was chosen as a humanitarian and disaster-prone area. Yemen and Nigeria, because of the humanitarian situation occurring in Yemen and also in the north parts of Nigeria, where also conflict is prevalent at the moment. The purpose of the studies that we conducted was to really get insights, good practices, and recommendations that can contribute to increasing the capacity of humanitarian actors for them to be able to respond to the needs, but also to the rights of groups that are affected by sexual violence, and also to improve the availability of services for survivors through the public system, but also through community-owned interventions. So we're also happy to see that there are quite a number of NGOs as well participating today to this webinar. The method that we have used for these multi-country studies was a qualitative research study. So we interviewed survivors of sexual violence. We interviewed also communities having to deal with high prevalence of sexual violence, but also key informant stakeholders, so organizations that are active around services on sexual violence in the specific areas. Next to the interviews and focus group discussions and key informant interviews, we also had held facility assessments to look at what kind of services are there available for sexual violence survivors. Next slide, please. So we had 4 specific objectives where we wanted to focus on in the study. So first of all, we wanted to focus on exploring how sexual violence in humanitarian settings is affecting people of different genders. Secondly, to assess what medical and psychosocial assistance survivors have access to, and what were the gaps, also looking at the gaps and the services available from a gender perspective. The third objective was to assess whether relevant international standards on medical and psychosocial services, but also if international human rights laws were adhered to, and that these standards as well from international WHO protocols and the international humanitarian law were applied to the services, so to the medical and psychosocial services. Fourthly, it was to assess what kind of good practices do exist already in these contexts of Yemen, Nigeria, and Haiti in this context, and what should be reproduced. So these were the 4 overall objectives that we had for the study. Next slide, please. So in Nigeria, we focused on Borno State, where Boko Haram has been active and in conflict since July 2009, so almost 13 years, which is a very long time. 8.5 million people are in need of life-saving assistance in Borno State, and 1.7 million are women of reproductive age who are affected by the conflict. And GBV is very high highly present. So 30% of the population is experiencing gender-based violence, and sexual violence rate is at 16%. In South Yemen, so the second research site, we conducted the study in Lai and Aden Governorate. Yemen is currently 7 years in conflict, and around 3 million people, or women and girls, are at risk of sexual violence. And at the same time, the economic crisis is worsening. There are numerous outbreaks and disease outbreaks and changing. The conflict lines are also changing, and there are a lot of internally displaced persons. So that's a bit about the research site in South Yemen. In Haiti, we wanted to focus on Port-au-Prince, Sud and Grand-Anse, because of the disasters that have happened. So in 2010, an earthquake took place. In 2016, Hurricane Matthew took place, and in August 2020, another earthquake. And 1 million persons are in need of humanitarian assistance. And also, there are alarming reports, for instance, by Médecins Sans Frontières, MSF, made that there is a high rate of sexual and gender-based violence, but there's still a lack of information. Unfortunately, as Tasneem explained already, in Haiti, we couldn't continue with the study, with the data collection, and those challenges will also be further elaborated on in this presentation. Next slide. Yes, and now we would like to present you the findings of the 2 studies that we were able to conduct. And first of all, starting with Nigeria. So the floor is to you, Diana. Over to you.
Thank you, Lindsay. I will be speaking to our findings in Nigeria, specifically in Borno State. Just a sneak peek of the findings. So in Borno State, we saw different forms of sexual violence from the findings, and when you look at the arrangement is not limited. We are not saying that these are the only forms of sexual violence that are existing in Borno State, Nigeria, but this is what we saw in the data, and it's arranged in ascending order. But also we saw that there were intersections within the different forms, particularly sexual exploitation and sexual harassment. We saw that here there were practices of transactional sex for survival sex. And also we saw that this tended to affect mobility, especially for young girls and women who go out for either going to school or to fetch water or firewood, but mainly in the evenings or in the late hours. We also saw that rape and sexual assault was also another form of sexual violence with intersectional. It was intersectional in terms of how it affected the different groups that we interviewed. But also we saw that the role of kunya had an impact on people to speak out or reporting. So kunya is a local term that is referred, that means shame, or that means shame. So people would be ashamed to speak up in terms of when they are sexually assaulted or when they are raped. We also saw that yes, there was rape within marriage, but this in terms of forced sex within marriage, so they would it wouldn't be reported as rape or regarded as rape, but those themes came through. Early forced marriage was also another issue, and mainly around with elements of bride price, early divorce, abduction by unorganized groups. These mainly were around livelihood activities, especially, like I said, when girls and women go to fetch firewood, or boys go out, they would be abducted. Also saw that there were also elements of sexual enslavement in terms of where they would take young girls to be young wives. There were also reports around denial of contraceptives among women, more to do with either they want more children because it's seen as an equivalent of more wealth, or some ideals around masculinity where men control the fertility power for women. And also another element that is also driven by social norms, that is around son preference. Other forms of violence that we saw that female genital mutilation or cutting, forced abortion and denial of abortion. We saw limited reports, and so these three forms were not extensively explored in this research. We also saw that most of the perpetrators of this violence were mainly family members and actors, like I said, the armed organized group fighters or community militias or security forces, or they could be neighbors. We saw some records for staff conducting humanitarian activities as also perpetrators of violence. Next slide, please. Our findings also looked at service uptake for sexual survivors. We saw that medical services were more available compared to other services like psychosocial services, but also saw that there was some presence of counseling and case management. We saw that the findings also indicated a gap in legal services and services around food provision, shelter, and livelihood, which indicated a gap for investment or call for investment. We saw that survivors actually were more focused on fulfilling basic needs like food and shelter than, and they ended up deprioritizing health services. The findings also indicated that services and protocols for abductees were more developed and standardized than for the other forms of areas of violence, which is also an area to look at. Community structures and community and support, community structures and support structures. Sorry, like we saw that aunties, women leaders, and the role of bulamas. The bulamas in this context are community leaders. We saw that these played a critical role in the prevention of violence, but also in referral linkages. Most activities, we saw that most activities around sexual violence were focused on anti-stigma work. Also, there was limited presence of sex cases for survivors, which would affect their privacy and confidentiality to access these services or to access information or speak up. Lastly, we saw that prevention work was actually limited, and especially that is targeting men and boys, and yet we know that in most of our settings, gender and social norms are actually peculiar and drivers of violence. With this, I will hand over to the next speaker. Over to you, Sarah.
Hello, everyone. Thank you for joining the call, for joining this webinar today. Before I start presenting on the results for Yemen, I would just like to emphasize that these results are currently have been recently reviewed by the Ministry of Health, and they are in the process of validating. So maybe sometime in the near future, we will have a detailed presentation that talks much more about these results. What we have here is just a very summarized snapshot of what we saw as some of the findings. So in Yemen, the study was conducted in Aden and Lahaj in the south of Yemen, and it was a process that was very inclusive of everybody in Yemen, all the stakeholders working for reproductive health, the main ones being the Ministry of Health. And then with them, we had some national partners, the governorate health offices, and also then our partners who are part of the reproductive health working group in the south of Yemen. So some of the results that we saw coming from this study, it was clear with the views of the respondents that it was the war and the vulnerabilities that were created by the war that actually were influencing the society and bringing about an increase in violence. And some of those that were mentioned were lack of security, breakdown of legal institutions, poverty, displacement, and a breakdown in general of the social fabric. So these were those that were mentioned by respondents when speaking about the increase of violence in Yemen. The respondents also mentioned that there was a widespread use of arms and drugs, and they believe that that was one factor that was leading to an increase of sexual violence in the areas of Aden and Lahaj. Rape was mentioned as one of the forms of sexual violence. And then when asked of who was probably most at risk, children were mentioned more often than adults, children and teenagers. And among children, there was the majority of the respondents reflected that the male child or boys were more at risk and were often mentioned much more than the females were for rape. Child marriage was also mentioned, and there was consensus among majority of the respondents that child marriage had been increasing since the conflict and over the years. Different testimonies and information was provided, and out of that, some mentioned that the youngest age group recorded was as young as 9 years. The incidence of sexual violence had definitely increased also according to the perspective of the service providers. So those service providers at the health facilities mentioned that they believe the incidence had increased. However, they also said that they were seeing less survivors. And the health facility data that we collected also indicates that not as many survivors actually reach the health facility for services. The perpetrators were mostly mentioned to be men. There was no particular description of them, but it was also mentioned that many times the men are known to the survivor. Women were mentioned in some cases, but mostly it was men. The respondents, both within the focus group discussions, the in-depth interviews, all mentioned that sexual violence was pretty prevalent at all levels of the society. So they mentioned that mostly it was around the households or in other public areas. So a lot of other detailed information was provided, and hopefully we will be able to share much more once we have our validation process completed. Next slide, please. In terms of the health facilities, and services that were being provided within the health system in Yemen, some of the findings were very positive. I think the biggest positive finding was that the Ministry of Health had particularly designated health facilities that were responsible for providing services for survivors. Now, this does not necessarily mean that this information was well known among the community. We kind of understand from the respondents that they were not very well aware of which facilities were those that were providing services for survivors. On the other hand, they also, those who did know also mentioned that sometimes those health facilities were not either functional or were not able to provide the full range of services. Again, while speaking to service providers at some of these health facilities, we were able to collect quantitative data from about 7 health facilities. And when speaking to these frontline providers, the majority of them had received training on CMR or some aspect of sexual violence. However, they were not all able to clearly identify the protocols that were used for the training. And the conclusion was that since those trainings were provided by different entities, so by different NGOs or UN agencies, so basically they were following the protocol that was used for a training. So there were different protocols that had been utilized for training for different service providers. Most of the facilities did say they were providing psychosocial first aid. There is some detail in the questionnaire that goes in depth, and I think that will be analyzed and also shared when we speak in detail about the Yemen results. In terms of who actually presented themselves to the health facilities, to the 7 that we went to, it was interesting to note that all age groups mostly had been there. So girls and boys, children, teenagers, adult women. The only age group that had not been seen in the past 6 months in any of the health facilities as a survivor seeking services were male above 18 years of age. And this is again interesting and kind of also correlates to the fact that the community were mentioning that male boys and teenagers were more prone to sexual violence. However, it definitely seemed like males who were above 18 years of age were not comfortable accessing services because they hadn't been seen. There was also evidence while speaking to the service providers and looking at availability of supplies that they had at their health facilities, that there was a lack of technical guidance on how survivors that were children and infant could be managed. And although a lot of work was being done informally with regards to referral, for survivors, including very prominent and impressive work being done by some of the national NGOs who were directly collaborating with some of these facilities. All these referral pathways were not formalized. They were not formal referral pathways. So it was mostly dependent on information that the service provider knew, or people or networks that the service provider had and knew where to send the survivor. When we looked at referral, we looked at not just the medical referral for complicated case management, but we also looked at referral for more detailed psychosocial care, referral for legal aspects, referral for to the police, to the judiciary, for lawyers, and for protection as well. So this was another interesting finding. These are the 2 slides we had for Yemen. As I mentioned before, we will be able to share much more, hopefully, in the coming future. I will now shift to talk about the challenges or some of the lessons learned challenges that we saw while conducting the study. And these challenges are more general, the ones I'll mention now, but then I'll go to some country specifics as well. So again, I think it was interesting to note that in the humanitarian, the three settings we had, um, it was clear that plans that are made for a research and for a study and for all that we put together as a project, there was a lot of delay or a kind of reassessing, replanning happening because of the political insecurity, because of shifting lines for conflicts, because of other things that were happening. So again, I think we were lucky in the aspect of this study that we had a lot of flexibility, both coming from the understanding of the donor, the understanding of the ministries of health that we were working with, and partners on the ground. But this is a reality for humanitarian context that we have to keep in mind. It took about quite a bit of long time to actually set up the whole study. So to do the desk reviews, we did desk reviews for the three countries, which were very useful. So one big lesson learned was to have that desk review. It was really, really useful because it gave us a lot of background information and a lot of help in fine tuning our tools for each of the three countries. But it took quite a bit of time to recruit our research team and to get buy-in from all our stakeholders, and to ensure that our protocols that were specific to the three countries and our tools were actually endorsed and agreed upon by everyone who was working in the country. So data collection happened at very different times. We were not coinciding our process of training and data collection for the three countries. Yemen was one of the first ones to happen, but then we had our COVID pandemic. So even Yemen's time lapse between collecting information from the community to the health facility assessments was a bit different. The visa processes for some of these settings can be challenging. The travel process can be challenging and something that has to be kept in consideration. Could take a longer time. I'm sorry for the interruption. If you just give me a second, I will keep speaking, but I'll switch off my video. So again, we witnessed a lot of delay when the COVID-19 pandemic happened for most of the countries. For Yemen, where we had already started the training, we had to change our methodology for the training. Some of us who had traveled internationally for the training, we had to change our plans and move out of the country quickly, and we left behind our colleagues who were there, who were our national consultant and the teams from Save the Children to follow through with the rest of the training. But again, because of the COVID-19 restrictions and the need to have proper PPE and the need to actually make sure that all our data collectors and those that we were meeting to collect data from were all kept safe, it was a process that had to be planned and managed. The team did very well in doing that, but while doing that, we also had to keep making considerations for a number of things. One of them was that the Ministry of Health, of course, was dealing with a very big crisis. They had to, like every other country was in the world, the Ministry of Health had to figure out a whole lot of other things. So actually going to the ministry and asking them to pay attention to our research did not make sense at that time. So many times we had to delay things because we knew that the COVID-19 response took precedence over anything else that was being done. Other times there were lockdowns where no activities could take place. But some of the things maybe and I'll talk about it later when I speak more in depth about our research and how we modify things. But some of the things that were clearly important were also looking at um, making sure that we have a very good oversight of what communities were feeling at that time. So trying to understand not only the security concerns within these communities, but also understanding the community perspectives to a pandemic like COVID, how feasible or how appropriate it was really then to go out and make sure that to go out and ask them to provide us information in terms of data. Next slide, please. If I speak about some of the technical considerations or technical challenges that we had when we were looking into this study as a whole, I think the first and the foremost one that is really important is that this is a very sensitive topic. I think it's clear to understand. It's not the topic that is daily discussed or well understood, or something that stakeholders and people working on the ground are able to work with very openly. So since it was a sensitive topic, it was very important to keep going back to the stakeholders and discussing and making sure that they're on board with the study and we all understand and are on the same page with regards to the study topic and what we're trying to get out as an outcome of the study. Again, it was sexual violence, I guess, in humanitarian settings is very, very prevalent. We know it's there. We know we have seen it in many other settings. So it's not unique to Nigeria or Yemen or Haiti. However, I think we also know that it is not always the first priority for stakeholders and ministries of health to work with, because there are so many other priorities that they're dealing with. So in such a setting where you have, the COVID-19 pandemic, you have other outbreaks. In the case of Yemen, at one point we had a dengue outbreak, we had other outbreaks, and then there's flooding, flash flooding was happening at the same time. So with many other things happening, trying to bring the attention and focus on sexual violence and the research that we needed to do, I think was a challenge as well, and very, very understandably why it was a challenge. Research in itself is not always a priority in conflict settings. I think this is also something we know. There is quite a bit of lack of information. And then if it is compounded with a pandemic like COVID-19, then research also becomes less of a priority for everyone who is trying to manage so many other things. So trying to watch carefully the external environment, trying to monitor the situation with the Ministry of Health and other stakeholders, and then finding those small pockets of time when we could actually go back and rediscuss that this is a research that we need to finish. It was also interesting to see that sexual violence, the terminologies and definitions and understanding was very different among stakeholders, even within one setting. So that was another challenge, bringing people together, discussing the terminologies, the definitions, trying to make sure that before we agree on the protocol and the tools, that everybody kind of understands it the same way. likewise, a sensitive topic, a new area. So training of the research teams in each of the countries was a challenge in that it took longer than maybe it would have taken to train for any other research topic. So there was a couple of things that were important. So first, understanding that the research teams had to understand the topic very well. So that took a longer time. Then also understanding that this is a sensitive topic and people will have to take maybe breaks, or maybe not everybody will have the same reaction. So keeping into consideration everyone's own personal reaction to a topic like this and to a training like this. And then also, of course, the challenge in the training in trying to ensure that role plays were done in the right way. Again, during data collection, it was important a challenge was also to keep or to make sure that our data collectors were not affected by what they were hearing. And if they were affected, there was space and provision for them to manage that in the right way. Next slide. In the next slide, this is more about specific challenges that were specific to the three countries. I think that I will not maybe go into the details of each one of them, but maybe the important lesson learned for me, at least in this, was from Haiti, where we had done all our preliminary work. We had gotten our permissions and approvals and had all stakeholders on board at one time, but still looking at the happenings in the country, the political instabilities, everything that was happening, it was important to make a decision that we wouldn't go through with the study because we did not want it to be to do more harm than good in the end. So I think this was a big lesson learned from Haiti for me. Again, I will not go through the details of this, but I think the next section I'll hand over to Lindsay. Thank you.
Thank you, Sarah. Yeah, so Sarah explained a lot of challenges that we faced during the three studies. And as she explained, we unfortunately had to pull out of Haiti. But to explain you more about the mitigations measures, first of all, next slide, please. We needed a robust and very active security follow-up because both studies were conducted in conflict settings. Security-wise, monitoring was very much needed to even adjust the study sites and to do no harm, not to the participants of the study and either to the research team in that sense. So it was also very necessary to work with high qualified researchers with very much experience in working in the context of Yemen and in Nigeria, but also that had expertise on gender-based violence and sexual and reproductive health and rights. Because as Save the Children and Kids, we had very difficulties to even go to the study areas due to the lockdowns of COVID-19. So we collaborated with a local and an international consultant who are stationed there or really frequently have conducted research, for instance, in Borneo State. As Sarah also explained, the collaboration with national organizations was also vital because they could really make a connection with the community to mobilize research participants, also survivors of sexual violence, but also other community members that could provide their perspectives. So we worked with national organizations that were active in the area on sexual violence. Other parts that we took as mitigation strategies, Sarah explained that it took almost 1 year at least to set up the whole study. And in this situation, you really have to calculate extra time to discuss with ministries of health, but also with reproductive health working groups to get everybody on board on this topic and the sensitivity of the topic around sexual violence. So the buy-in is really essential, and it took 6 months in certain contexts. So there is also we have noticed that you really have to get agreement on terminology and definitions. And this can be done by unpacking the term of sexual violence. As Diana also mentioned, like rape in marriage doesn't exist in the context of Nigeria. So we used forced marriage, forced sex in marriage as other concepts. But we also had to work with local languages, so to make proper translations and to find that agreement with reproductive health and ministries of health on the terminology and definitions used. And the desk review and the mapping of health facilities who provide services was also essential to make the tools that we developed in general, to make them very context specific and have enough background information. So with regard to the training, we had to do a lot of adjustments because of COVID-19. So a lot happened more online, but luckily we had also the support of the two consultant researchers who could still support the research team. But also it was necessary to work in smaller groups with like 3 to 4 persons, and also to spread the training to collect data, but also for the analysis to spread it out for a longer time period. And because of the sensitivity of the topic, and that how you question or how you conduct interviews with, for instance, survivors of sexual violence, that they don't relive their trauma, it's very important that the research team had extra skills on that and learned. And we did that through role play as well, or making a lot of use of role play and yeah, trying out piloting interviews. In the data collection, so for COVID-19, we adjusted some of the methodologies. For instance, focus group discussions were held outside with enough distancing, but still that it was feasible to do focus group discussions. Personal protection equipment was provided to all research participants, but also research teams. And yeah, to give a proper follow-up on COVID-19 precautions. We ensured the safety of study participants, but also, of course, the confidentiality. So everything what is shared that remained autonomous. And we also took, of course, consideration of the security situation for the research team. So on a daily basis, they got briefings about security. And this was also an advantage of working with Save the Children, with the local office, who are very much knowledgeable about the security situation and how to respond to it. With regard to data dissemination, we have postponed a lot of meetings as well, because certain, as it is sensitive data on sexual violence and the outcomes, it's not always appropriate to do things online, to have these meetings online. And that was also the feedback from the local Save the Children officers, that we really have to have face-to-face meetings. So that's why we sometimes had to just postpone and wait. And for instance, Sarah got the opportunity finally to go to Yemen, so she could meet everybody in the Ministry of Health in person to discuss the findings than doing this online. Next slide, please. So there was a lot of adjustment needed. If you see that we initially planned the project for 2 years, in the end it was extended with 1.5 years. And this yeah, so it was continuous process of being flexible to adjust the timelines, the plans, and the budgets. But it was also so important that there was a willingness on the part of the donor ECHO, um, but also the national stakeholders, so the Ministry of Health, the reproductive teams, and the research team to be able to adjust to the circumstances that were coming up during this study period. And again, the collaboration with local expert researchers was also essential to be able to still collect the data. And that's why in Haiti, we couldn't find um, a researcher. That's why it was also one of the reasons why we pulled out in the end, although there's such a high sexual violence rate and the need for research, and there was funding for it, but still we didn't want it to do harm. So next slide, please. With regard to the overall reflections that we have of the study, is that it was very good to have a partnership between Save the Children as a humanitarian aid organization with a lot with local offices in place in the context and in the countries where we conducted the research. So everybody had its own added value, and as KIT as Knowledge Research Institute. So there was a profound contextual knowledge available to maneuver in these politically complex settings. But also the Save Children local offices had a network and relations already established with the reproductive health cluster, with the ministries and other local NGOs and the communities where the studies were conducted. So that is also vital, not only for the dissemination, but also in the whole setup of the study. So all these important stakeholders who in the end have to give follow-up to the studies and the recommendations, that they are engaged from the beginning, and also in the situation of the validation and the dissemination of the findings. And Save the Children was on top of the security situation, so they regularly informed the research team and to ensure their safety and security. Also to be aware that knowledge is political, so it's also very important to be conscious about what kind of dissemination approaches are used, as it shouldn't negatively affect any implementers, what is being shared. And in this context, the reflections that we have, they count for any humanitarian or conflict setting. And these lessons, it should be used, and the recommendations should be used to improve the sexual violence services for survivors and for the communities, and not for any political reason. So KIT's experience was our added value as KIT was that we have a lot of experience in conducting research on sensitive issues as sexual and reproductive health and rights and sexual gender-based violence, and that we always work in collaboration with local research teams on and offline. So we had that experience to facilitate trainings and to strengthen the capacity of the research teams in the development, design, and the analysis. And as we have also experienced already before COVID with a lot of online trainings as well, this was easy to maneuver in this context. Finally, also ECHO's flexibility was essential, and their engagement as a donor. So they really were flexible and to postpone the data collection, and always were in discussion with KIT and Save the Children on how to progress, and but to not do any harm with data collection or dissemination of the findings. Next slide, please. and then some ethical issues that we took into consideration that are very important. So it's one of them is also providing referral mechanisms for study participants to the NGOs and health facilities that are active on sexual violence. And this was also part of the consent process, so that study participants were aware where they could go for services or which NGOs are supportive in that sense. And also the interviewed survivors and community members, that the focus was really not to do not no harm, but that it went beyond that to do more good. So one of the approaches that was used was appreciative inquiry. That meant that during interviews, the research participants were free to share and to start and to explain about their own stories. As I said before, we didn't ask them about their experience on sexual violence, but because we were really interested in what kind of services or what kind of support was provided. But still, the survivors wanted to share some of their experiences. And yeah, so they had a lot of space to express and to share what was on their heart on that. So these were the reflections, and this is the end of our presentation on the general findings that we had on, but also the challenges and the mitigation strategies with regard to the Research for Change project in Nigeria, in relation to Yemen, and in relation to Haiti. Thank you. Tasneem, over to you.
Thank you, Lindsay and Sarah and Diana, for a very interesting, insightful, and presentation with a lot of food for thought. We already have some questions that are coming in the chat, which Katie has been great enough to make a note of. And the floor is open for speakers. What I will do is I will stop sharing my screen so we can have a look at everyone here. So if others wish to put on their video, that would be great to get a sense of who's in the room. And Katie, I think you have put down all the questions. I made a note of them. And I'm wondering if our speakers here would like to already start with addressing a few of them. And if elaboration is needed, you can invite the person who asked the question to speak up. So give us a few minutes while the speakers have a look at the questions, because we have quite a few. So maybe I can assign. Sarah, do you want to? We had a question from Ganga Gautam. One of the findings in Yemen talks about the violence against boys. Could you elaborate on the nature of violence to get a sense of how they suffer?
Yeah, thanks, Tasneem. I think the study clearly highlighted that boys were more often mentioned than girls with regards to sexual violence. So that was a very prominent finding. There was also mention of rape, but I think it's very important to contextualize this. And I think the important point here is that boys are most probably more exposed outside the households than girls are in those settings. So I think this is also another aspect of the context that is very clear. So boys are actually leaving the house, actually doing things outside the house. So their exposure and the risk is much higher. And that's why this finding kind of, I think, justifies what was happening. There is some information from health facilities on boys or survivors who were boys who came through, but I would like to also emphasize that we will be sharing many more details later. But I think clearly this is also one aspect that needs to be addressed when we train our frontline service providers on medical services. So the medical services post rape for boys and girls and how it should be appropriately managed medically, I think is one other thing that was pretty obvious that needs to be addressed. And maybe not just for Yemen, but maybe for many other contexts where sexual violence is prominent. Thank you, Tasneem.
Sarah, if I may I ask you to follow up because there's a very similar question from Christine. You mentioned that there were also boys and men raped. Was it easy for you during the data collection to exchange correctly with them on the subject?
So I would like to emphasize we did not directly speak to children survivors. We decided we will not do this in this study because it's not that I think Save the Children does conduct research with children and on very sensitive topics, but being a child-focused organization, there is a very long protocol to follow for that to be done. In this study, our respondents, we had adolescents, we had youth, but we did not have child respondents, definitely not children who were survivors. We did have a lot of testimonies that came up from the respondents. And those testimonies were speaking about people that they know of, people that are in their neighborhood or their friends or relatives or friends of friends. So that's how we have quite a bit of information from those testimonies.
Thank you, Sarah. We have a question from Renu Gulwalkar. Some of your question, Renu, has been answered by Sarah, but let me repeat your question and perhaps Lindsay can come in to give you a response. For data collection with survivors, what methodologies did you use to ensure that survivor confidentiality is taken care of? Elaborate whether you interacted with children for data collection. How did you handle issues around consent? And can you elaborate more on the do more good approach? So Lindsay, perhaps you can just discuss consent and the do more good approach a bit more. And maybe Diana, you want to come in because in Nigeria this was used. So the floor is open. Lindsay, you're on mute.
Yeah.
We still don't hear.
Yes.
Great.
Thank you, Renu, for this question. With regard to confidentiality, we have a whole process and protocol that we put in place. So not only for survivors, but for all participants that join the study. First of all, we go through an extensive consent form so that all research participants are thoroughly informed what the purpose is of the research, what are the objectives, why we are conducting it, how we want to use it, and also, that we guarantee anonymity, and that's done as well by only recording the interviews or focus group discussions and then anonymizing as well the transcripts after, and that there are no reference to any name, and that will also not be traceable back in any reporting. So like that, we have procedures in place that we respect not only for survivors, but also for any participant that joined into the study. The second question was the good approach. yeah, I think I explained a bit that it's also how we approach the participants in the research, especially survivors of sexual violence. First of all, that they want to join and participate in the research in the study is it's yeah, admirable, not only because yeah, it's still they have to express, or we will ask them on what kind of support there is, and if there's hardly any support, that can trigger certain feelings. So in that sense, we really make sure that there is support from health facilities for survivors, but also the connections with NGOs, what I also elaborated in the presentation, but also that they are free to express. And yeah, that's an interview method as well, that people yeah, can feel, instead of directly asking through a topic guide how they certain kind of questions, to give that space for the participant themselves as well in what they want to express. So that is the approach that was taken. And maybe Diana, you want to contribute to this question as well from the side of Nigeria, because in the Nigeria study, this was more emphasized.
Diana, would you like to come in?
On the do more good approach, I think with this particular study, we took more of the appreciative inquiry. So it's more start with the comfortable questions to sort of explore the positive experiences before you land the hard questions. So more from a safeguarding approach. That's what I would say about it.
Thank you, Diana. We have a question from Claire. You are speaking about the SRH clusters. Did you also interact with GBV subclusters? Sarah, would you like to take that?
Yes, we actually did do that as well. We initially, when we started the study, we contacted the GBV clusters as well. And for Yemen, at least, I think it's important to note that the study was in the south, so we didn't collaborate necessarily with the level in the north. So all our coordination and collaboration was happening in the south with the Ministry of Health and the GBV and SRH clusters.
Diana, would you like to come in for Nigeria?
Kindly pardon the question.
Whether we engaged with the GBV subcluster.
Yes, we did engage with the GBV subcluster from the beginning, right from when we were developing protocols to get them to actually review, check the language, make sure that we are aligned with the practice within the country, but also being culturally sensitive and language sensitive to the approvals. And throughout the process, even in the validation process, we had the GBV cluster contributing. So yeah.
Thank you. We have another question from Florence. Florence, would you like to actually unmute and perhaps ask your question so we hear some other voices? Do we hear Florence? If not, then I read the question, no problem. So Florence asked, did the research take into consideration the effect of the COVID-19 lockdowns on sexual and gender-based violence? The evidence shows that there was a much higher prevalence of SGBV during lockdowns. It seems that the research looked at the COVID situation only as an extraneous factor. Lindsay, Sarah, Which speaker would like to come in? Sarah, shall I give you the floor?
Sure. Yeah, I think there is, you're right, we were not able to look at directly any of this, and there are reasons for it. I think, first of all, our study happened at the time when the first and second waves of the COVID pandemic were happening. So it was right, kind of coincided with the very start of the pandemic. So I think these considerations were hard to make anyway. The second thing I think that comes to my mind is these are settings where we don't have a lot of reliable information anyway to establish prevalence or incidence of sexual violence. I think it's very hard. When we did our desk reviews, it was very hard to really find data and information that was available that could represent the study sites we were looking at. So to then go back and establish whether the pandemic increased the prevalence in these settings, I think is a difficult aspect. We tried to look at some of the health facilities that we assessed much later in the timeline of the pandemic, but the reality is that the data coming from these health facilities has not really changed. So it was kind of on average the same number of survivors presenting themselves as they were in the initial health facilities that we had looked at. So I think it's an interesting aspect to measure, but it would require a setting where we have a robust data collection system or something at least that allows us to compare to. I think, I don't know, Lindsay, what you think. And also, I think it would have to be consciously designed into the study design as well, I think, to then establish that relation. Thanks.
Yeah, to come in on that, indeed, that was not the purpose of our study, and the methodology was mainly qualitative. So we really looked at service delivery and the types of sexual violence that were occurring in the south of Yemen and in Borno state. So that was not the purpose. And there's another question as well related to that, if we have any statistics. Again, this was not a mixed method study where we were looking into the incidents of sexual violence, but really, what kind of response is given to the needs of sexual violence survivors. So that's a different kind of purpose. And in the setting of Nigeria, we did see what we heard from the interviews with the community and stakeholders engaged was that child marriage increased due to the conflict. So maybe the conflict even had bigger implications for a lot of girls in relation and women in relation to the sexual violence that is occurring than COVID-19 itself.
Thank you, Lindsay and Sarah, for your response. We have a final question from the chat, and then we have still a few minutes for perhaps an open conversation. So our final question is, what is the use of telemedicine in emergency situations? And we do have some insights from our findings also from Nigeria. So Diana and Sarah, would you want to respond to this? Sarah or Diana?
Yeah, sure.
Great.
Yeah, I think it's a area that is of great interest, and I think we should explore. Is something that we can look at, but it would require, in the settings that we conducted these studies in, I think it would require a lot of focus on many aspects before we can really say that, you know, a telemedicine project would work or not work, or would be able to serve the needs of women. But I think it is something that can be explored. It does not exist at the moment, definitely. I know more of Yemen than Nigeria. It's not something that is there at the moment, but I think in a conflict humanitarian settings, there are a lot of aspects that need to be considered when introducing and new things. I guess that would be my answer.
Thanks, Sarah. Diana, do you want to share?
Yeah, in the context of Nigeria, we saw that the use of hotlines as an alternative option to provide safer information and also linkages to services for survivors as one of the best practices, especially in areas where victims do not access health workers because of distance or for any other reason. So I think it's a good opportunity to leverage the learnings to link that with the hotlines and introduce telemedicine. So yes, I think in Nigeria there is potential.
Thank you, Diana. So we have about 9 minutes remaining, and we need about 2 to 3 minutes for closing remarks. But before that, I would like to open the floor. If there are any other participants who have a question, you can unmute yourself and ask the speakers the question. We also have, we would also be keen on hearing if you, in your experience, since a considerable number attending today have worked in such settings, what have been your experiences in mitigating some of these similar challenges that perhaps you may have faced? And it would be great to also hear a bit about that. So the floor is open for any questions or reflections. Yes, Christine, you have your hand raised. Please, you can take the floor, and if you could limit your...
Ok, merci pour la parole. Je parle à partir du Congo, la RDC. J'apprécie vraiment toute l'équipe par rapport à cette recherche. C'est une très bonne chose. Mais je voudrais discuter, demander lors de focus group, est-ce que parmi l'équipe qui interviewait, il y avait des psychologues? Parce que pour moi, je me suis dit, bon, peut-être qu'il y a eu ces femmes ou hommes, lorsqu'ils ont parlé de leur cas et qu'ils ont sombré vraiment dans leur état traumatique. Est-ce qu'il y a eu des psychologues dans l'équipe de ceux-là qui ont enquêté? Et deuxièmement, c'est par rapport à l'équipe qui a enquêté. Est-ce que cette équipe a aussi reçu un soutien psychologique parce qu'ils ont reçu beaucoup d'informations qui pouvaient aussi les traumatiser? Voilà un peu ma question. Merci.
Merci, Christine. Lindsay, would you be okay with summarizing a translation and also responding?
Did you hear the question, Tasneem? The
Yes.
translation? Oh, yeah, that's good. Yes.
But it would be good if you can just summarize the question for the audience in English.
Yeah, so the question was if we had any respondents among the study participants that had a psychological background or were working in the area of psychology or psychosocial support. And the second question was if we also had support from psychologists for the research team. We were hearing quite some intensive stories, life stories, sometimes from some participants. Those were the two questions of Christine from Congo.
And Lindsay, do you want to respond? Or perhaps Sarah?
Yes, I would say yes. We had arranged for services to be available for all the study team. So we had people available on call in case someone needed. We also provided that information actually much earlier on, even before we started the training, so that they can be comfortable contacting and talking to someone. We were also available, many of us ourselves, to see and to understand and monitor. So yes, those services were made available.
Thank you. Diana, Lindsay, do you want to add something? Maybe Lindsay on the team composition, if we had.
Yeah, among the team itself, we don't have any members that have a social background. But as Sarah said, we provided support, and on a daily basis, actually, yeah, that can also be seen as a form of counseling, that the research team were debriefing and telling what was going on and what they experienced. So to bring that release as well. But in the end, there was no need for extra psychosocial support than the support given by the lead researcher and the research team. The team managed to deal with what they heard and the stories they got, but it was very intense at the same time.
Great. Well, not great about the intense, but great, great response. Thanks, Lindsay. We have time for one final reflection or question that the audience may have for our speakers today. Another brave soul like Christine. Is there anyone who wants to take the floor? Okay, so there are no questions. So I assume the speakers did a great job of explaining the study and the findings. Well, then I would like to thank all the participants here today. Thank you for the questions, the discussions, and for taking time to join. For those who were present in our last webinar where we presented findings on Nigeria, I hope this added a different dimension to those findings. As Sarah explained, we will also be having another webinar. We hope to have another webinar where we dive a bit deeper into the study findings from Yemen, and we will be sending around an email about that once there is more clarity. Finally, the study report for Nigeria is available online, and Katie will be pasting the link in the chat for you to be able to access the report. The recording for our last webinar, but also for this webinar, is available on the same link, so you can have a look. And the recording will also be sent around in the different languages after we close for today. If there is nothing else, then I wish you all a wonderful day, and thank you everyone for joining in with us today. Thank you to the speakers and the participants.